Welcome to another episode of Heart Success. This is our amyloid series where we will be spending one episode each on light chain amyloidosis and transthyretin amyloidosis, which is AL amyloidosis and TTR amyloidosis respectively. For this episode on TTR amyloidosis, we have a national expert with us, Dr. Matthew Maurer from the Division of Cardiology at Presbyterian Hospital, Columbia University in New York. Dr. Maurer is a national expert in amyloidosis and is currently the medical director of the HCM Center at NewYork-Presbyterian Hospital. As a general internist and a geriatric cardiologist with training in advanced heart failure and cardiac transplantation, he has received innumerable grants, including grants from the National Institute on Aging to study cardiovascular changes in older patients. He specializes in the care of patients with heart failure and preserved ejection fraction, including patients with HCM, including patients with cardiac amyloidosis. He is currently an associate professor of medicine at Columbia University, College of Physicians and Surgeons, where he directs the Clinical Cardiovascular Research Laboratory for the Elderly at the Allen Hospital of New York-Presbyterian Hospital. He is a member of the Advanced Cardiac Care Center at New York-Presbyterian, Columbia. Dr. Maurer received a Bachelor's of Science in Biomedical Science as part of the 7-year medical school program at CCNY, the Sophie Davis School of Biomedical Education, where he was awarded the Bella Zeller Scholarship. He received his MD degree from the Mount Sinai School of Medicine and graduated Alpha Omega Alpha. He subsequently completed his training in internal medicine and cardiology at New York-Presbyterian Hospital, Columbia University, where he was chief medical resident. For those following the recent literature coming out for treatment in TTR amyloidosis or transthyretin amyloidosis, Dr. Maurer was the principal investigator for the aTTR ACT study that was published in the New England Journal of Medicine last year, which brought about one of the first drugs shown to have efficacy in treatment of TTR amyloid cardiomyopathy, namely tafamidis. For this interview, we've gone ahead with a slightly different format. Garima Dahia, whom you've heard from before in previous episodes, she is currently a resident from Allegheny General Hospital, going on to be a cardiology fellow in Minneapolis, Minnesota, who will really be leading the conversation in this interview today as we maneuver and tackle this relatively complex disease. Welcome to Heart Success, Dr. Maurer. Thank you so much for coming to our show. And is it okay if we call you Matt for this conversation today?
Yeah, of course. It's actually Matt with one T, though. Couldn't afford a second. So.
Right.
Before we get started, however, Dr. Maurer or Matt, could you tell us maybe a little bit outside of academics, your interests and things that keep you going?
Oh, yeah. I like to play tennis, and I obviously enjoy my family and my kids. Most notably, recently, I've seemed to become a big fan of Holy Cross football. And that's because my son, who graduated from Penn State, is a coach there, and the Crusaders won the Patriot League. So, congrats to them, and pretty proud. He's a good guy. So he's having early success in the world of football, college football.
Sounds great.
That's absolutely incredible. Moving on to our show, Dr. Maurer, I recently came across an article titled, "When You Hear Hoofbeats, Think of the Treatable Zebras." While cardiac amyloid was, it previously fell under the category of the zebras of medicine and was considered a rare entity compared to other causes of heart failure. Currently, amyloidosis, and more so TTR amyloid, is increasingly being recognized as a common cardiovascular condition in older adults. But despite increasing awareness, in one of your recent surveys of aTTR amyloid patients, you noted that 17% of all respondents reported visiting at least 5 different physicians before receiving the correct diagnosis. More than 50% of the mutant TTR patients received a misdiagnosis or received treatment for a misdiagnosed condition. In your opinion, what are the main barriers to a timely diagnosis of this disease?
Yeah, well, It's a great question. I think first and foremost is the perception or misperception that it's really a unusual or rare disease. By the FDA definition, a rare disease is one that affects less than 200,000 people in the United States, which if you multiply or divide 200,000 by the population in the US, it actually turns out to be about 55 or 60 people per 100,000. Interestingly, there's a paper that was published by colleagues, Dr. Darbola and others at the Brigham, looking at a national Medicare database of hospitalized patients. And in 2012, so even before, the advent of new treatments, scintigraphy, and everything else, amyloid was prevalent in 55 or some odd per 100,000 already. So first and foremost, I don't think it's a rare disease, especially transthyretin cardiac amyloidosis. We talk about systemic amyloid being unusual, and articles are written that AL is the most common form of amyloid. I'm 100% sure that with the aging of the US and worldwide population, notably the fastest growing segment of the population is those over 85, that the most common form of amyloid will be transthyretin. So the first problem is that it's thought to be rare and it's not, and so people don't put it on their differential. The other impediments are that it affects a cohort of people who are older, who have multiple other concomitant comorbidities and potential other explanations for what are usually very non-specific symptoms. They complain of fatigue, effort intolerance, and shortness of breath, and there are lots of things that can cause that. Having said all that, I'm sure we'll touch upon it later, there are lots of, people call them red flags. To me, red flags is where the oil is buried. These are highly specific findings that strongly suggest a diagnosis. So it's, again, the nondescript nature of the presentation, the general sense that it's rare, and the perception that it's hard to diagnose. And by the way, I'm not a rocket scientist. It is not hard to diagnose once you think about it.
You raised a good point, about the perception that it's considered a disease of the elderly still. I've myself come across reports of diagnosis of the wild type aTTR being diagnosed in patients as young as 47 years. What is the prevalence of, the wild type TTR among younger adults, or is there an age cutoff that you consider while thinking of that diagnosis?
Yeah, it's a great question. So generally, I believe this disease is highly indolent and slowly progressive. I personally have not seen people under the age of 50 with the diagnosis, though there are rare case reports. The reason I think, though, it probably begins in your 50s, maybe in your 40s, is the following observation, right? If you look at the aTTR ACT trial and the data, the patients had a wall thickness of 17 millimeters, pretty thick, right? They had an EF, obviously preserved, of 45, but their stroke volumes were really low. There were 45 mLs, stroke volume indexes of 25, as low as in any form of heart failure. And they have markedly elevated troponins at baseline and NT-proBNPs of 3,000 and global longitudinal strains of 9. However, the patients have a NYHA class, despite all those really bad findings of, NYHA class of 75% of the patients were class 1 or 2. So how is that possible that you have such a bad cardiac phenotype, but it's not that symptomatic? And that's because I think it's very, very slowly indolent and probably begins at least a decade earlier than we're making the diagnosis. And that is going to be incredibly important, that early time, lag time, to find those people, because that's when these drugs work the best. So, the prevalence in general we've talked about is, in heart failure with preserved EF is described by one small paper. It says about 13% of people, again, with heart failure, preserved EF in a hospital, who have an increased wall thickness. So you have to have those kind of criteria. So again, I think it's more common than we think, but probably not that common in people who are, 40. But start to think about it when people hit 60 or above. Mm-hmm.
Right. And, we were talking about the course of the disease and the indolent progression of it. Could you just elucidate the pathophysiology of the disease a little bit for us?
Oh, yeah. Basic scientists have really informed us a tremendous amount. So transthyretin is also called prealbumin. It was given its name prealbumin in 1970 at Columbia University, where I worked, because it was discovered in DeWitt Goodman's lab. It's a small protein that on electrophoresis, which is the only technique that was available in the early 70s, it segregates in size before albumin. So hence it was called pre-albumin. That was its first name. It's the nutritional marker that many of us draw in patients, particularly on surgical services to see if their nutritional status is okay. Subsequently, they figured out what the protein does, and so they renamed it Transthyretin or Transthyretin. So it transports thyroid hormone and retinol. That's how it got its name. It's a protein made in your liver on chromosome number 18. It's 127 amino acids. It folds in a certain way, and the protein links together one monomer with 3 other monomers to form the normal 4-leaf like clover structure. So it exists as a homotetramer, or just for patients, we say a 4-leaf like clover protein. And mutations in the protein and or aging is associated with the protein dissociating or falling apart into monomers that agglutinate into the fibrils, and they get stuck inside your heart. So knowing that biology, liver production, folded, tetramer, dissociation to monomers, there are 3 kind of strategies to treat the problem. One is, stop the production, either give a liver transplant or silence the protein with drugs in the liver. These drugs don't work in the other area where the protein's made. 99% of it's manufactured in the liver, but 1% is manufactured in the choroid plexus in the eye. And then the other drugs are stabilizers that prevent the protein from falling apart. And then there's the concept of degrading the amyloid that's already there.
Right. We've talked about the perceived misperception of the disease, and you raised that point of red flags and when the diagnosis should be considered. For someone who's currently an internist and to be a cardiology fellow next year, when should I keep this as a high differential on my list and consider screening a patient for aTTR amyloid?
I'd say, the obvious areas in the setting of anyone who has an increased wall thickness. A wall thickness is over, God forbid, 14 millimeters, are highly specific, or I should say highly sensitive for this particular condition. They obviously can occur in other disease states like hypertrophic cardiomyopathy or other infiltrative disorders like Fabry's, but that's one of the quintessential, especially increased wall thickness with no stimulus, right? So no really uncontrolled hypertension, no aortic stenosis. That's one of the quintessential things. Obviously, patients develop a syndrome of heart failure early on. They have a preserved ejection fraction. So HFpEF, particularly in older adult males without hypertension. Patients often are intolerant of usual heart failure therapies. They don't really like ACE inhibitors, angiotensin receptor blockers, RNA therapy, beta blockers. Why? Because they actually have a normal blood pressure to start, and so you sometimes lower it too much. So that's a sign, intolerance to standard heart failure meds. And then there are these orthopedic manifestations that are, pretty useful. About 60% of the patients we take care of have had previous carpal tunnel releases. Pretty specific. So if you take 100 people with heart failure and carpal tunnel, I would strongly suggest you think about TTR amyloid. And the same is true for what we call carpal tunnel of the spine. That's lumbar spinal stenosis, and also a bicep tendon rupture. So those orthopedic manifestations are really important clues. Most people think about it truthfully, though, not in the clinical history realm, but unfortunately after an image. So there are also imaging clues as well.
Right. So how important is this history of carpal tunnel and the biceps and spinal stenosis in considering screening a patient of amyloidosis? Would you tend to lean towards screening them a little bit more routinely?
Yeah, so I have a little bit of a problem with the term screening. So to me, screening is done in people who are obviously asymptomatic. I don't think at this point in time we know that any therapy in patients who have absolutely no symptoms with myocardial uptake of PYP, so they have the disease, would be effective. So I prefer the term, this is maybe semantic, of active ascertainment, because I don't think that we should be running out there and screening completely asymptomatic folks. Like we do for like cancers, mainly because I don't think we know, the cost effectiveness of that or other things. So again, I use the term active ascertainment. I think there is, some evidence that, certainly in the setting of clinical syndrome, all the things I just mentioned are useful. There have been more developed programs to quote unquote screen patients, and I think clinicians have to decide. To his credit, Maz Hanna and his group at the Cleveland Clinic basically took 100 patients, was published in JACC, slightly less than 100, and they quote unquote evaluated the tissue from the carpal tunnel releases for amyloid and found it in about 10% of folks. And they found active myocardial disease in a handful, 2 or 3, at the time that they were getting their carpal tunnel releases. So I think everyone has to decide, is that a yield that really we should endorse? 3 out of 100. I think screen for it more actively, but I don't think I'm convinced, let me put it this way, that we're going to have a active ascertainment program and a quote unquote maybe screening program, but I don't think anyone knows who is the right group to screen, what the right group is, and we need a lot of data on the outcomes of those folks, whether they do better, whether it's cost effective, and so forth. We can talk later, but we're actually involved in a large screening study in New York that we got funded by NHLBI to screen, but we're not really screening people. Because they're symptomatic, they have heart failure. We're looking for amyloid in people with heart failure.
Considering the data shows a high proportion of patients have cardiac amyloid deposition in autopsy studies within hearts. So I think this is a question that comes up from time to time. Where does amyloid in the heart get pathologic, or where do you call it the disease amyloidosis, and where is it just a representation of old age?
Yeah, very important. So there is data, just so you know, in a few series from Europe in which they leverage DBD scintigraphy. So this is a bone scan that's been done in hospitals for decades. You can take all the bone scans that were done in your hospital. So let's say there were 20, 30,000 of them, and you could send your poor fellow to look on all of those scans to find out who's got myocardial uptake. All of those patients, it looks like about 1% of women and 3% of men over the age of 75 have myocardial uptake on a scan, and obviously they weren't getting the scan for a heart failure reason. They were getting the scan for some other infection, metastasis or some other thing. So it's pretty common that the scan would be completely positive. Having said all that, you mentioned that pathologically, if you were to do an autopsy on folks over the age of 75, it would be 25%. So you have to have, I think, as far as we understand it now, enough of amyloid in there for it to be, quote unquote, amyloidosis as contributing to the phenotype. I personally think the scans that we're doing, scintigraphy, does identify the cohort that has enough disease that you would call it amyloidosis as opposed to amyloid. An interesting hypothesis is how much does this, small deposits that may not result in us calling it amyloidosis, how much do they contribute to the phenotype of HFpEF? That's going to be pretty complicated to sort out. But I don't think we're talking about prevalences, to be honest, like we talk about on autopsy of 25%, even though that's what people talk about. The data seems to suggest it's in all comers, less than 5% in some odd who have amyloidosis at that age.
Yeah. The natural course of TTR amyloidosis, like we briefly mentioned, really includes progressive heart failure, complicated sometimes by arrhythmias, conduction disease. So in your practice, when you see these patients, how does TTR amyloidosis typically present? Maybe we could also go into if there's differences between wild type and mutant TTR, how they present and how they evolve.
So, my practice is somewhat biased, right? I'm an amyloidologist, so I see people with amyloid, and I'm an advanced heart failure doc. So most of the patients I see are referred in for the clinical syndrome of heart failure. I think the other phenotype that I've seen is patients who have atrial arrhythmias for years. Often they have atrial arrhythmias and AFib, God forbid, in their 50s, as we talked about, young age, 60s. Got a few ablations, and no one ever really appreciated they had an infiltrative myopathy. So those are the two common groups that we see with this particular clinical syndrome. The other just comment about natural history is there was a really great paper from the National Amyloid Center in London. Elaine's the first author, Julian Gilmore is the last author, that was published in Circ. But in a large series, about 1,000 patients, they describe the natural history, and it's pretty sobering. The patients, by the way, were hospitalized on median of 17 times after their diagnosis. So it's a pretty, a disease that impacts greatly on one's quality of life. To your point about hereditary versus wild type disease. So obviously it depends highly on the mutation, but since we're cardiologists on the call, I'm going to stick to the common mutations that affect patients, and particularly in the US. And so wild type is most common. Second most common is called the VAL122 ILE mutation, which is also called the Afro-Caribbean mutation. almost exclusively affects people of African-American descent and Afro-Caribbean. We've seen, interestingly, a few patients who are Italian, and our colleagues in Italy have identified a few white individuals, Caucasians, who are Italian descent who carry the mutation. And it's pretty clear, again, from the NAC data that those patients have a worse phenotype in that they progress at a faster rate than wild type. And the other big mutation in the United States is what's called ALA60 or THR60 ALA, alanine replacing threonine at the 60th position. It's also called the Appalachian mutation, or it's discovered in Northern Ireland by Mary Riley, actually. And it causes a pretty significant neuropathy along with a cardiomyopathy. So the spectrum of hereditary disease is you could either have a pure cardiac phenotype, that's mainly wild type or V122I, though V122I probably has some neuropathic manifestations in some patients, or you could have a pure neuropathy. The classic one is something called V30M, where methionine replaces valine at the 30th position. That's called Portuguese mutation. We don't see that very much in the US, but that causes a bad neuropathy in young people. And then you could have what we call a mixed phenotype. Interesting, the THR60 ALAs don't seem to do as poorly as the wild type or V122I patients, but they're also usually about 10 years younger. So whether that's a benefit to being a little bit younger when they're diagnosed.
And like you mentioned, even in practice right now, we have all these companies offering different amyloid genetic testing for free to a lot of our patients with our potential disease. How do you involve, considering the complexity of the matter, genetic counseling into your discussion with these patients? And do you use genetic counselors to do a lot of it?
Yeah, so look, you can't diagnose the condition without doing genetics, right? So you can't, from a past specimen, you can use mass spectroscopy and try to figure out if there is a mutation, but that's not the gold standard. The gold standard is genetic testing. To be honest, I actually have wonderful colleagues in genetics and do rely on them when needed, but this is not very complicated. And I think every cardiologist out there needs to embrace this, especially a heart failure doc. These tests are easy to do. You do it blood or saliva, right? So they take about a week or two for turnaround because it's a small protein. They basically sequence all 4 exons of the protein, and the protein is only 127 amino acids, so it's not very large. And you get a result. Either you have a mutation or you don't. It's not like something where there are novel mutations usually being discovered often. Surprisingly, we do discover one once in a while. In the last year, we discovered one, and a colleague on Long Island did, that hasn't been reported, but that's pretty unusual. So it's all pretty straightforward. What do I tell patients? I tell them the benefits of getting tested, which is obviously we know now whether you have a genetic cause, it's inherited in autosomal dominant fashion. Therefore, any family member who's a first-degree relative, mother, father, sister, brother, kids are all at risk. And so they can be then informed of that they carry a mutation or not if they want to get tested. I tell patients that the GINA law, the Genetic Non-Discrimination Act, passed by George Bush, does not allow in the United States anyone to not get health insurance on the basis of their genetic information. So it's illegal for someone to say, you have a gene, I'm not going to pay for your health insurance. But I tell them that they can be denied life, disability, and long-term care insurance. And so, in general, the patients I'm seeing already have heart failure. So no offense, they're going to get denied life, disability, and long-term care on the basis of the fact that they have heart failure, whether they have a gene or not. If they're really asymptomatic, then I think those patients need to consider that, and I urge them to go get their insurance, and then they can come back a few weeks later and get it done. If we wait for everybody who we want in this world to go see a genetic counselor, there's going to be delays in diagnosis that are already bad. 3 or 6 months, you add another 3 months onto that, that could be really impactful. So I think we all need to roll up and figure out how to do this. But people have to be comfortable with that. It's really not that hard, and the genetic counselors are happy to teach you how to have this conversation. I've been taught. I do, I think, a reasonable job, and when it gets confusing, I pick up the phone, but I literally pick up the phone 1 out of 100 patients, and it's probably not for this disease. It's more often for, a variant of unknown significance in some panel that I've sent. It's not that hard here.
No, that's a great point. Absolutely.
Mm-hmm. And Dr. Maurer, there's a frequent coexistence of aortic stenosis, especially low flow, low gradient severe AS with aTTR amyloidosis. Does coexistence of the latter affect outcomes post-TAVR? And do you think endomyocardial biopsies at the time of TAVR should be practiced more frequently among these cases?
Well, to the latter question, no, because if you wanted to diagnose patients with TTR, you could do it non-invasively with scintigraphy, assuming they didn't have a monoclonal protein. And no offense, biopsying someone, certainly pre-TAVR, right, who has AS, that would not be a smart move, in my opinion. You know, if you induced an arrhythmia in someone who's got bad aortic stenosis and some AFib, you could kill them. So I would not recommend people run around and biopsy. There are centers that do biopsies. They almost always do them in these patients. For example, if you suspected AL, they almost always do them if they're going to do them after the TAVR is done. Certainly 1 out of 7 patients is what the data shows in not a lot of big series, but we had 16% at Columbia of people undergoing TAVR in a consecutive series of 151. It was 22% of men, so it wasn't rare. Other series have been a slightly lower. Some of them have been SAVRs, so surgical, and they've been younger. But it's the general number, if you want to know, is 1 out of 7 patients has amyloid. So I think it's something to think of. To your point, we hypothesized years ago that this would be the explanation for low flow, low gradient AS. It's not that simple, by the way. Half the patients we identified in what we called the Unveil trial did not have low flow, low gradient AS, despite having amyloid. So I don't think you should just do screening in low flow, low gradient AS. Mainly the paradoxical low flow. We did show that if you have a mitral annular S wave that's less than 6, those are the people on a routine echo with AS who basically probably have amyloid. And so if anyone wants to read the old Unveil paper in the European Heart Journal, we took the 150 patients, we cut them down to a group of 75 by using the mitral annular S wave. And then that 16% overall became 32% because we weren't scanning everyone, even though in the study we scanned everybody. We don't know if it affects outcomes. I can tell you, I shouldn't say we don't know. We know at our center whether it affects outcomes. It's not yet published. It will be hopefully soon. We literally submitted the paper this week. But we and other series that I've reviewed recently suggest that surprisingly, and I would have thought patients with amyloid did much worse post-TAVR, they don't appear to. And the relief of the AS may be very important in these patients. And there's a lot of emerging data that's going to come around. The second thing, just to comment, that everyone talks about, in the world of screening and active ascertainment is, let's screen the AS patients. I think it's fine to identify people who have it, but I don't think that's where we want to be spending our money. These are 80-year-olds who are pretty sick, and it's pretty clear that earlier drugs is better. And these people are never early when they have aortic stenosis and they have amyloid. They're pretty late with their phenotype. So if I had to design a next trial, it would not be in late phase patients with AS. I'm sure it will get done because cardiologists have access to those patients, but I don't think that's the best population to leverage for new phase 3 studies of novel stabilizers and silencers.
And going into how we diagnose this disease. So you did mention something very important, that we don't need biopsy to diagnose someone with TTR amyloidosis. So maybe you could tell us a little bit about your approach to diagnosis.
Yeah, you don't need a biopsy if you don't have any evidence of AL amyloid. So look, we all have known how to treat AL amyloid for decades. We have anti-plasma cell therapy. Every week the oncologists have a new anti-plasma cell therapy. Kind of unbelievable. I call it oncological envy because they can get everything approved at the FDA on a surrogate endpoint every week. But their drugs are amazing and they work really, really well. The first step is, if you consider amyloid, there are 2 main types. There's AL and there's TTR, and you have to exclude AL first. So the first test you want to order is assessments for monoclonal proteins. You want to order a serum protein electrophoresis with immunofixation, not an SPEP, but an SPEP with IFE, saying to the lab, I'm looking for small protein. And you want to order a kappa lambda free light chain in the serum, not in the urine, right? And you want to look at mainly the ratio there. There's a slight kappa predominance that goes up a lot if you have renal insufficiency. But in general, if the ratio is abnormal and there's no renal insufficiency, you have a monoclonal protein production. And you want to order a UPEP on a spot urine with immunofixation. If those tests are negative, then you do not have the substrate for AL amyloid. Then if you went on to scintigraphy and it was positive, then you have TTR, then you phenotype. So it's a very simple 3-step process that could all be done on one day. Bloods for monoclonal protein, PYP scan, or scintigraphy broadly, and genetic testing. Now, if you have a monoclonal protein, it doesn't mean you have AL amyloid. It probably means statistically, most commonly, you're going to have TTR with a monoclonal gammopathy of unknown significance. But you can't be 100% certain. You're no longer 100% specific with scanning. So you have a patient in front of you who have monoclonal protein and a scan that's positive. They probably may still have TTR, but you don't know for sure. And the biggest problem in amyloidosis is misdiagnosing the type and the precursor protein and mistreating the patient. So if you have monoclonal protein, then you should go on to a biopsy. AL amyloid can't be diagnosed without a biopsy. Now, the art in all of this is that, these are 80-year-old people you're evaluating. And so the prevalence of monoclonal protein, depending upon your definition, could go to 40% in some series. In our paper with Gilmore, we reported a prevalence of 19%. And I can tell you that, when you see enough of these cases, right, when you have a grade 3 scan and you have, a kappa that's a little high, but renal, you can get rid of a lot of the quote unquote false positive monoclonal proteins. In general, we need to biopsy about 10% of patients still, but we don't need to biopsy half of the patients. So I think if you're out there biopsying 50% of your patients, there's some problem in your approach. I think if you're biopsying nobody, there's a problem in your approach, and it's somewhere in between, and we can all agree or disagree. And the other thing I just say is, don't forget, as a cardiologist, to ask your colleagues. A hematologist who sees this all the time can kind of tell you that that degree of light chain abnormality is most consistent with, a monoclonal gammopathy of unknown significance.
And when you mention biopsy, are you referring mainly to endomyocardial biopsies?
Well, for AL amyloid, what are the alternatives? So what could you do? You could do a fat pad biopsy, but the bottom line is a fat pad biopsy, in the best case scenario, has a sensitivity of 75 or 80%. But that is in a scenario where there's multi-system amyloid in a bunch of organs. So, the range of the sensitivity of a fat pad in AL is as low as 30% and as high as 70. But even at the highest, right? If it's negative, you still have to go on because you're not sure that you've excluded the disease. Bone marrow biopsies are positive in very, very few patients with AL at the time of a bone marrow. Even if people have amyloid, right? They don't see the amyloid in the bone marrow. In my experience, it's less than 10%. So as Willie Sutton said, we're heart failure docs. When you need to do a biopsy, you go where the money is, and the money's in the heart. So it's not a big deal, to be honest. This is the disease, remember, in the ACC, AHA guidelines, HFSA guidelines about biopsy, that has the highest yield of an endomyocardial biopsy. You make a diagnosis in a thick-walled heart with HFpEF more often than all the other scenarios, and it's pretty hard to perforate these people, right? They have thick-walled hearts. You have to work at it, which is the mainly feared complication. So the answer basically is, in my practice, if you need a biopsy, you get a heart biopsy.
Yep.
Mm-hmm. Dr. Maurer, I attended one of your lectures last year that you took at Allegheny General, where you talked about the distinctive patterns of strain seen among amyloidosis patients. Could you talk a little bit about the role of strain in its comparison with cardiac MRI among these patients and cost effectiveness of each as well?
Yeah, so obviously everyone gets an echo nowadays, and I think it's a perfectly appropriate test. Gives you a lot of information. There are a lot of clues on a standard echo. There's obviously symmetric increase in wall thickness. We talked about it. But remember, wall thickness on an amyloid is not always symmetric. So if you see some asymmetric hypertrophy, do not think it's hypertrophic cardiomyopathy, especially if they're over 60 always. 25% of people who are diagnosed with HCM have amyloid, actually. They're misdiagnosed. And there's a great paper by Maria Fontana and Jack, in which by MR, only 18% of the patients who she imaged with amyloid had symmetric increases in wall thickness. So the first message is wall thickness, right? We know what the patterns look like. Their atrium are big, their valves look a little thickened, they're never looking too normal. They have a lot of intra-atrial septal thickness. That's a big finding. And they also have, interesting, what I call the linea alba, you remember, in your abdomen. They have a line in their septum that's pretty bright that you can see. On tissue Doppler, I'm not speckle strain right away, but just regular tissue Doppler, they usually have in the advanced phenotype a low tissue Doppler velocity, high EE prime, but obviously the pattern of strain is useful in that a lot of patients have with this cherry on top or apical preservation, where the apex moves and the base doesn't. The opposite of what you'd see in an acute or a previous anterior infarct, where the apex is down and the base is moving. And that has a pretty good sensitivity and specificity in the studies that have been done. There aren't many of them. It's about 80, 85%, maybe, some would say up to 90. So it's kind of unbelievable. All these warning signs we were just talking about, low voltage to mass, orthopedic manifestations, the Doppler stuff, all of which by themselves each have 80 to 85%. So if you put them all together as a clinician, it's pretty easy. The big warning, other caveat though, is I've seen people who have chronic kidney disease and bad hypertension who are African-American who have that atypical sparing pattern and don't have amyloid, so there are mimickers. MRI, obviously you see, increase in wall thickness as well, increase in extracellular volume. You can see altered T1 mapping, T2 mapping, all of those particular phenomenon. I have to say, like 5 years ago, before PYP was advented, I got what I would call the peak and the squeak MRI from everybody. What's the peak and the squeak MRI? That's the MRI on the patient who some doc was taking care of for 5 years, had the blahs, had a normal EF, started to get sicker, they didn't know what was going on, and they're like, I'll just get an MR. And the MR said at the conclusion, this person has amyloid. And that peak led to a squeak. They screamed, they freaked out, they were embarrassed, they didn't like to miss the diagnosis, and so they essentially sent them off to the amyloid center. That's gone away because, to be honest, MRI is expensive, can't do it in patients with pacemakers. Obviously, if you do a non-contrast study, you can do it in people with CKD, but in other patients you can't. Patients have to lie under the machine, they're elderly, and it doesn't give you a definitive diagnosis, just suggests you have the phenotype. So PYP is to replace that. The other big important message, I think, is the following. If you suspect amyloid, right, especially, for example, in like a 50-year-old who's got a monoclonal gammopathy and AL and has other features, and you do an MR and it's negative, remember, it's only got a sensitivity of 80 or 85%. It ain't perfect. So if you stop there, you've just 1 out of 7 times missed the diagnosis by not biopsying people. So once you especially entertain AL, I know we're talking about TTR, you really, really, really got to go all the way. And so all of these tests, I think, are good, but none of them are perfect. And I think in imaging, echo and PYP are doing better. MR is going to emerge as the best way, I think, to follow folks. So I think it's going to have a big role in the context of, measuring ECV and measuring the response to treatments.
That's a good point. And let's say once you've actually diagnosed someone now with TTR amyloidosis, any prognostic markers that help risk stratify these patients?
Yeah. There are 2 staging systems that have been developed. Martha Grogan's in the Mayo Clinic, in which in wild-type disease, she used an NT-proBNP above 3,000 and a troponin, a T that was above 0.05. In the high-sensitive range, that's probably above 65 or 75, in case people are using that in their labs. For troponin I, it's probably above 0.1. But basically, if you get none of those points or both are low, you have a median survival of 6 years. Again, that doesn't mean they're going to live 6 years. My junior faculty likes to try to tell people how long they're going to live. I think that's a mistake. I mean, these are averages. These are all untreated. But median survival of 6 years if you're early, 4 years if you're intermediate, meaning one of those are high, and 2 years if you're late. Those are the averages. And the same biomarker system that was validated in a much larger group, including hereditary folks, was done by Julian Gilmore and colleagues. And it uses the same NT-proBNP cutoff of 3,000, but it replaces troponin because every lab's different. I just mentioned the different cutoffs. And it uses EGFR of above or below 45. So if your EGFR is above 45 and your BNP is below 3,000, you have early disease. If one of them is positive, you have intermediate or late disease. And it's about the same survivals that have been shown. Remember, these are all untreated patients. There's probably some other, there are better ways ultimately, I think, to risk stratify, but we haven't figured them all out yet.
Dr. Maurer, earlier in the show, you talked about how one of the clues for picking up on amyloidosis would be clinical worsening while these patients are already on, typical guideline-directed therapy like beta blockers, ACE inhibitors, ARBs, calcium channel blockers, and so on. So other than diuretics, sodium restriction, and aldosterone antagonists, are there any other meds that constitute guideline-directed therapy among these patients?
No. And the truth is, there's probably, I hate to be critical, but there's no guideline-directed medical therapy for HFpEF in general, right? I mean, just, as soon as your EF's, 40, 45 or higher, I don't think we really know. Now, there's a big debate, obviously, in the heart failure world for what we cut off we should use to define reduced ejection fraction, and maybe we should creep that up to 50 in some of the general measures. But certainly in amyloid heart disease, right? These people have low and fixed stroke volumes. If their heart rate is 90, leave them alone. They don't need a heart rate of 60 because they're keeping their cardiac output up by keeping a fast heart rate. So beta blockers are bad. If they have AFib with a really fast response of 120, 130, which is very unusual in amyloid because they have concomitant conduction disease. They don't go fast. So when they flip it to AFib, they're usually self-controlled, rate controlled. Then you can use a low dose of a beta blocker, but you want to use like metoprolol, dilating beta blocker. ACEs MRNA therapy, probably in early disease, you might be able to get away with, but there's no guideline-directed medical therapy. And the bottom line is the patients feel tremendously better when I do a few things. They come and see me and they're on all of those guideline-directed medical therapy. I stop them or wean them off. Why? Because they're living with a blood pressure of 90. Their volume overloaded. They're tired and fatigued. I take all that away and their blood pressure comes up to 110. Now I have the blood pressure to give them, torsemide and bumetanide, a bioavailable diuretic with an aldosterone antagonist. They lose 6 or 10 pounds. That coupled with the fact that I probably told them that they didn't have AL, so they thought they were going to die in a few months, and they have TTR, you're like the greatest doctor in the world for about 6 months. And then they realize you haven't done much really for them, and it's, back to the usual. The other thing I would just say is, from PYP scans or scintigraphy, those isotopes of calcium binding, you could learn why it's a really bad idea to give a non-dihydropyridine calcium channel blocker like verapamil to an amyloid patient. Right? They come to the ER, they have amyloid, they're in AFib with RVR, and you decide you're going to give them IV cardizem, I'll see you in a court of law because you're probably going to end up converting them, but you may end up stopping their heart or causing shock. And I've seen that happen. And so if you know they have that disease, that's a contraindicated medication. So I hope that's useful. Main role is diuretics. And don't forget, we don't need a lot of diuretics. They could also just stop licking the salt, eating the Chinese food and pizza,
right.
Work on the supply side, just the demand.
Right. You arbitrarily mentioned like a heart rate of 90. Is there an optimal heart rate range that you target in these patients with the symptomatic benefit?
No, I mean, I think, to the opposite, sometimes we put pacemakers in these patients. We set them at 60, and if they're really in low flow, you may want to increase their rates. But I don't think we know what there's an optimal heart rate. And, life is up and down, guys. We walk, we move, I think we know when it's way too fast, above 110, and I think we know when it's way too slow. And after that, I think we spend too much time doing things that are not very useful for patients. But definitely, we spend a lot of time doing it.
Right. And and when it comes to patients with AFib and amyloidosis, is there like a preference in terms of rate and rhythm control?
Most importantly is anticoagulate them, right? That's the bottom line, right? So if they have AFib and they're in amyloid, don't look at their CHADS-VASc score, just give them a blood thinner. We have data we presented at HFSA. We're trying to get published now. It's not a great study because it's our single center experience, but NOACs are just as good as warfarin. No difference, but much easier to manage, I think, because of the dietary issues and the, out of range in the INRs. They seem to work pretty well in these patients. So the bottom line is that's the one medical therapy I actively survey for AFib in these patients, right? Everybody with amyloid develops AFib. Half of them have it at the beginning in my practice, and 90% of them have it by the, end of their practice with me. I mean, it just happens. It's universal. And so if you don't see AFib, they're either early in the disease or, you missed it. And so I tend to monitor these patients, with, not an implantable loop, but something pretty long for a week or two, because there ain't nothing that changes your life more than having a stroke. So that's the one message I think that's unequivocal good medical management. And there's a lot of data emerging about, cardioversions and other things and being careful. These, not as much as AL, but these people have intracardiac thrombi.
So what about this role of cardioversion? Do you routinely give most of your patients an attempt at cardioverting?
In general, again, depends, the phenotype and where they are. I do generally offer people. The bottom line is what you observe clinically is when they first go into AFib, they notice it, they feel bad, and over time they don't notice it. It's just something the body gets used to. I'm a little torn because, to be honest, if you need to TEE every 80-year-old who's got amyloid before cardioversion, and believe me, I've given lots of people Coumadin for 3 weeks or, Eliquis for 3 weeks, never done a TEE and cardioverted them and haven't, knock wood, seen a stroke. But if I'm going to force to TEE everyone and then find out that 50% of them have a clot, and then I'm going to re-TEE them every 3 or 4 weeks till the clock goes away, I think that's too much for many of these patients. So I tend to divide the patients into a 2x2 box. How symptomatic are they in their AFib, and how likely are they to stay in sinus rhythm? And if you're really, really got a big atrium, you don't feel anything, and you're not likely to stay in sinus rhythm, I'm not running to Cardioversion you. And if you're, early in the disease and really symptomatic, we certainly can give it a shot. And if you're not sure about your symptoms, sometimes we'll do that. Most people don't stay in sinus rhythm without a drug, and the only 2 drugs you can use are, dofetilide or amiodarone. You can't really use anything else.
Right. And currently, there are no HRS or ACC-AHA indications for primary prevention ICD insertion in these TTR patients. Do you typically refer any of your patients for ICD implantation?
Never. Not never. That's too strong. Very, 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 very rarely. These patients have heaps and heaps and heaps of non-sustained VT, but they do not seem to die suddenly. There's, I think, a physiological possible explanation. Remember, you need a reentrant loop and you need a slow and a fast pathway. These people have so much diffuse disease throughout their myocardium that I think they have lots of non-sustained VT, but they can't set up a really, reentrant circuit. Having said all that, I think we should be very clear. The data out there is very scatty and not clear. People have put in defibrillators in folks and reported high rates of quote-unquote appropriate shocks. I can tell you, if you put a defibrillator in amyloid patients, they have so much non-sustained VT, they're going to get a quote-unquote shock. I'm not sure it's appropriate. It's going to save their life. So that is an endpoint we actually learned from systolic heart failure. It wasn't the best endpoint in the world, especially when we learned to put the rate up to higher. So I think the jury's out, but I can tell you, these patients rarely, if ever, die suddenly. The patients who I have had defibrillators in who had an appropriate shock almost inevitably had concomitant coronary disease. They did not just have amyloid. So there's a downside, by the way, to putting a defibrillator in, I just say. And that is, you put a big lead across the tricuspid valve and you make their TR worse. You could take a restrictive cardiomyopathy that's somewhat difficult to manage and make it impossible to manage. The RV is bad. The forward stroke volume goes in the wrong direction. Their CVP, which was 8 or 10, goes to 15. Their cardiac output goes down because now they have more TR. Their blood pressure declines, and they get into a worse cardiorenal syndrome. I've definitely done that in my earlier career, enthusiastically thinking I should put a defibrillator in these folks. By the way, back to pacing, I think a lot of people need a pacemaker. About a third of patients get a pacemaker. And when we do that, we don't have great data. But we try to put a BiV in them because these people don't like to be RV paced because they already have a low stroke volume, and then they get the synchronous. And they're all pacemaker dependent. The beauty of a BiV is it doesn't go across the tricuspid valve. So, there are some advantages there that may be useful, but that's, I think, needs to be tested in a broader way. Both defibrillators and pacemakers.
Right. And what if your patient is listed for cardiac transplant? Does that skew your decision-making at all?
No, not usually. But, look, if you're going to transplant a patient with amyloid in today's system, you're putting them in the hospital, right? They're going to be a status, with the exception criteria, to upgrade them if they have bad hemodynamics. They're going to be a 3 or a 2. They could be a 4, but we don't transplant many 4s in the new UNO system. So if they're in the hospital, what do they need to have a defibrillator for? Right? I mean, they're sitting in the hospital. You can get there.
Right.
So, moving on to therapies, we didn't really have any randomized control data until recently when you published data from aTTR ACT for tafamidis. So maybe we could talk about the different targets of therapies you alluded to initially, block protein synthesis, stabilize the tetramer, and maybe in the end, like you said, remove the fibers using different drugs. What are the different medications you use in your practice directly directed towards the protein?
Yeah, so silencers are patisiran and inotersen. These one's an siRNA, a small interfering RNA patisiran, given IV every 3 weeks, concomitantly administered with steroids, Benadryl, and Tylenol. Inotersen is a sub-Q agent delivered once a week. Has some significant side effects that were reported, low platelet count and glomerulonephritis. So it needs to be administered under an FDA REMS program, and you have to check labs pretty frequently, weekly. So there are advantages and disadvantages of both. These are approved, to be clear, for hereditary TTR polyneuropathy. You got to have a neuropathy. You can't get it because you got amyloid in your heart. You have to have amyloid in your nerves and a clinical syndrome. You could have amyloid in your heart too, but you must have hereditary disease, not wild type, and you must have a neuropathy. That's their approval, and no one's paying for them unless you meet those criteria. They're $450,000 list price per year, so ain't a bargain. Stabilizers, as we said, the only two that we got are diflunisal off-label. It's a non-steroidal. It's dosed at 250 milligrams twice a day. Works pretty well, in my opinion. Can be used for patients who meet the following criteria. They're adherent. You can speak with them. They don't have a stinky kidney, so their eGFR is above 40. They're not on high-dose diuretics, i.e. Lasix more than 80. Certainly no metalazone. They haven't recently been in the hospital. And then we could debate whether you could give a non-steroidal while they're on a blood thinner. I think you can, but some people are worried about that. I certainly don't add diflunisal to, triple therapy, like blood thinner, aspirin, and, a Plavix or something like that. So tafamidis is the same kind of agent. It's a stabilizer, obviously has none of those side effects. So, of course, that makes it not a penny a day, but $651 a day. So I hope it's 650 times better than diflunisal, and everyone should think about that if it really is. But that's the cost. That's the list price. I don't think anyone's paying. There's a wealth of good data. And then there's another stabilizer in development called AG10, but can't be gotten until it's approved. And obviously there's an active phase 3 trial. Those are the two things. For cardiologists, the only thing you can use for pure isolated cardiac involvement right now is tafamidis or diflunisal. You can't use the other things. And then the whole idea of removing amyloid from the organ is very much the American way, right? The American way is everything sucks and fall apart, and now I'm going to resurrect the patient. And that doesn't work, right? It's just not going to work. So, you're not going to scrub out the amyloid. And so while there have been drugs, particularly an anti-SAP antibody that was in the New England Journal years ago, 3-4 years ago, GSK stopped its production. The data on doxycycline and other agents is pretty stinky. And so if I was telling people, don't let the disease progress and try to get it out, maybe that'll work one day, but find people early, do genetic testing, actively ascertain, and start these therapies as early as possible.
And you mentioned, one of the big things today remains the cost associated with using tafamidis. Tafamidis currently is being approved at 80 milligrams. Could you use 20 milligrams?
Oh, absolutely. Yeah. There's no doubt. The problem with using 20 is going to be Pfizer. Next year, they're not going to make 20 milligrams unless we all stand up and scream. Tafamidis meglumine, which is what Jeff Kelly, the inventor of tafamidis and an absolutely brilliant, fantastic scientist. All the credit for tafamidis is Jeff Kelly. He developed the drug in his laboratory, right? Tafamidis meglumine is what we used in the trial. It is tafamidis linked to a salt, meglumine. It was dosed to 20 milligrams for neuropathy. We came up with a new dose in the trial. To be honest, in the trial on hard endpoints, whether you took 80 or 20, it didn't matter. So for CV death, hospitalizations, overall mortality, both worked. There's some data that's emerging. It's not, in my opinion, very provocative, but the biomarkers tend to go up less. They're still going up, but they go up less on 80 than 20. Whether that's worth, that much money. So you could tell a patient, look, I gave you 4 pills to take every day. If you want to save some money, take 1 pill every 4 days as opposed to 4 pills a day. And then you just cut the cost of tafamidis by 75%. Obviously the sponsor won't be too happy with me saying that, but if they want to lower the price, then we can think about it. The problem is that they came up with tafamidis free salt, which is what is called Vindamax, right? The new agent. Because once they learned the drug worked, they said they wanted to come up with it for convenience, right? Easier for patients. They only have to take 1 pill a day as opposed to 4. I say BS to that. The real reason they came up with it is because they don't want people taking 1 pill every 4 days and them not making their money. They want to give people 4 pills, and you can't split the tafamidis free salt. So, look, I don't encourage people to take the lower dose because I think more is probably better. But it's not better in the realm of, we know of over 30 months, death and hospitalization. And if, you want to eat, that's the difference. It's not an unreasonable thing to do, in my opinion.
And I've had to do that when the copay is just exorbitant. So it's cut the cost, like you said, by 75%.
Yeah, it's a shame. It's gross, right? Look, it's a great drug, and I'm happy they won. But, there's got to be some reasonableness about all of this. But whatever.
there was a recent paper that was actually quite interesting, which looked at serum TTR levels and monitoring response using these levels. Do you think this is where we're headed in the future?
Yeah. So that's the AG10 phase 2 trial. It's pretty clear that when you measure pre-albumin levels clinically, you're measuring the tetramer. The assay doesn't measure monomers. So if your protein's falling apart and you have, I'm making it up, a level of 25, but half of it is falling apart, then you're going to have a level of 12 and a half as opposed to 25. When you take a stabilizer, the levels acutely go up, and they go up within a month, probably even sooner. What happens with AG10 is not unique to AG10. It happens with diflunisal, and it happens with tafamidis, and probably happens to the same degree with, in my opinion, all of them. We presented data about tafamidis' increase. We're actually looking at now as a biomarker. So in the original phase 2 trial of AG10, they hypothesized that because diflunisal pre-albumin levels are prognostic at baseline, right? If you have a low level, you do worse, and a high level, they hypothesized that by raising the level, we're going to make people better. But that requires prospective confirmation. So we're doing that now, and we have a hint that that's the case. We're going to present, we hope, data at the International Society of Amyloid. But it looks like when you take tafamidis and your pre-albumin levels go up a lot, at least over a year's time, a fellow in our program, Sunil Safe, has been working on this data, but the event rate is very low. It's like 1 out of 20 patients was in the hospital. And when you don't increase your pre-albumin, those are the people who look like they have higher, heart events. Whether we could use that ultimately as a biomarker to say, it's not working, let's switch to something else, that would be, really good advance, but we don't have enough data for that yet.
We briefly spoke about cardiac transplantation in some of these patients. Current classification system, like you mentioned, you really do need exception or them to be really sick to be able to qualify.
Yeah, it's not that, well, yeah. I mean, there's the guidance document. I actually co-authored it. It's pretty straightforward. All that matters is what's your cardiac output. When your cardiac index is really poor in these patients, their blood pressure is low. So if you're not that sick, you become a 4, but you get listed as a 4. I'll be honest, AL patients I think are sicker than TTR, and we didn't dichotomize them, but I personally would be much more worried about an AL patient. But if your cardiac index is below 1.8 on no inotropes, you become a 3, again, with hemodynamic monitoring and other evidence of, hemodynamic instability, low blood pressure, high creatinine. And if you need inotropes, they don't work that well in these patients. And your index is below 2.2, then, you could be a 2. So that's the approach. Look, the main goal, though, right, let's be clear, is to get rid of transplant, right? The goal is not to transplant more of these patients. Yeah. It's to use these therapies and get rid of it. To quote Lynn Stevenson, right? What did Lynn say? To try to treat heart failure with transplant is like trying to cure poverty with the lottery. It's like illogical. It doesn't make a lot of sense. So the goal here is not to do transplants for these folks. I mean, we can do it still. Well, by the way, the number of transplants in UNOS last year doubled for amyloid. It went from 1% to 2%. We doubled all the transplants or increased them, but amyloid went up partly because people are recognizing it more.
Mm-hmm. Mm-hmm. Any role for using liver transplant in some certain populations, or just...
Yeah, we use liver transplant only in people who have obvious mutation that's associated with neuropathy, and they don't have a bad neuropathy. So it's mainly the ALA60s. We don't give liver transplants routinely. It makes the whole process more complicated. It's not really necessary, and we have these drugs. Again, we haven't yet leveraged them, but we think that we can leverage them post-transplant to eradicate the protein. To be honest, the patients, it's all an emerging field, but we have 15, 20 people at Columbia we transplanted with TTR. We used to do a liver transplant 10 years ago. Then we had a catastrophe and a guy who we gave a liver transplant to, and we didn't need to. It was just for prevention. And so we had a bad outcome. We're like, why are we doing this? We stopped doing it, and now we see some of the particularly V122I patients, and rarely a wild type who didn't die of their heart disease because they got a new heart. 5 years after transplant, they're developing a bad neuropathy. And so, this whole dichotomization in neuropathy, cardiomyopathy is probably arbitrary. If you live long enough, the protein would get stuck in the nerves in the heart in everyone and would cause a phenotype. So that's an interesting observation.
Mm-hmm. And what about the newer therapies that are still being investigated, like antibody-mediated removal of deposits or gene editing? Do you think any of them hold particular promise in the near future?
Yeah, well, I mean, I think the antibody idea is really, interesting. But as we said, there have been a lot more antibodies that have failed that have succeeded. So I'm all for the idea. You just have to have, the other thing is, getting the amyloid out of the heart. Who knows if that's a good thing or not? What's going to replace the space or other things. The gene editing is pretty cool. I mean, CRISPR is a great idea. And obviously this is a monogenetic, disease. So there are companies that are definitely working on CRISPR techniques, and they got an interesting pathway to regulatory approval, because you get one of these infusions and in theory, you eradicate the whole existence of the disease, who to study and, so forth. But I think this disease is on their, hit parade as number 1 or 2 up in there in companies that want to silence proteins through CRISPR. So I think it's interesting and it will be a good model, but it's a little bit far away.
And I think in our conversation today, we established that it is relatively easy to diagnose TTR amyloidosis compared to several years ago with the introduction of PYP scanning especially, and its availability at most centers. Do you think that TTR amyloidosis care has moved to the community and should not just be at large centers? Compared to AL, I think, which still has a role because of the chemotherapy.
Yeah, I mean, the most important thing to diagnose this disease is just put in your differential. Once it's in your differential, like I said, it's not hard. I'm a little torn. On the one aspect, I think there's so many patients and I have to wait a while to get that's appropriate. On the other side, I think people need to know what they're doing. And if someone's going to, we didn't talk about this today, but PYP scans are like any test. They're not perfect. There's a false negative rate and there's a false positive rate. There's a big false positive rate with grade 2 scans that are blood pool. People do not have anything related to amyloid. If you're going to misdiagnose someone with TTR amyloid and prescribe a $225,000 a year for a disease they don't have, we're going to piss away a shitload of money in the United States, right? I mean, it's going to be crazy. So that part may really require a second opinion. I've definitely seen people, thankfully in my practice, who haven't been prescribed tafamidis, but people who are, thought people had amyloid, and they have no phenotype that looks like amyloid. They just have a, slightly increased wall thickness and a low EF, and they have ischemic heart disease. So, I think there's some expertise, but, that's on us, the amyloid community, to educate people. Just as a shout out, there's a master class in amyloid. So if you're starting a center and you're interested, people can come. It's run by the Amyloid Research Consortium. A bunch of experts get together. We're doing the first one in Dallas early in January. It's online, but the attendance is in person. But we're going to talk about PYP scans and have people read them and learn a little bit more. But, I agree. I think it could push out to the community personally.
Yeah. Mm-hmm. I mean, thanks. That was a really great and comprehensive review for TTR amyloidosis. Thank you for coming to our podcast, sharing your expertise with us. Any last pointers, any other myths for amyloid that you'd like to bust?
Nope. Thanks for having me. It's really a pleasure. And all my best to everyone for a happy and healthy holiday season.
Thank you so much.
Yeah. Be well, guys.
Thank you so much, Maurer.
If you enjoyed our episode, don't forget to like, subscribe, and give us a high rating, as it helps other listeners find us. You can leave your suggestion for topics, critiques, things you think we can do better. You can email us at heartsuccessteam@gmail.com. You can actually find us on our website at www.heartsuccess.info. Our website now also provides links to all the podcast providers where you can listen to this episode. You can find us on our Facebook page at Heart Success Team, or you can always reach me on Twitter at CardioBro.